Well, thank you very much, Victor, for that introduction. And let me just also say how pleased and honored I am by your leadership on this very, very important issue. It really is so critical to all of us. I also want to thank Harvey Feinberg for his leadership as well. When he called myself and Dave Walker and asked us to co-chair this review, we were quite honored by that, and indeed then privileged to work with 19 other extraordinary individuals, and as you've heard, an exceptional staff who labored with love over the course of nearly 2 years. Lots of debate, lots of discussion, lots of public testimony, lots of review of literature and data to reach the 5 recommendations that we've brought forth with you and for you today. Bear with me, my voice is a little bit on the edge today. I want to also acknowledge the reality, as you've heard from Victor, that we were building on the extraordinary contributions that the Institute of Medicine has already offered in this area. Approaching Death in 1997, When Children Die in 2003, set the stage for our work. But when we began our work, much as you've heard from Dr. Zhao, we realized that our nation still has a long ways to go in really improving the approach to individuals facing death. And while we can talk about this as providers and caregivers, it's a deeply personal issue that affects every one of us, because we will all at some point be in the situation ourselves, which mandates that we really look critically at how we would like to die, just as we think about how others in our service would as well. So what we observed as really connected to our statement of task, as you've heard, is that our health system, unfortunately, is still fractured, not organized in ways that really leads to the kind of progress that we need to make, that we are, despite all of our efforts, still not engaging individuals in understanding their preferences and needs. And we haven't adequately even trained our medical community, physicians, nurses, social workers, psychologists, and others to carry out these very important conversations. Of course, we realized, as we'll talk about today, that there are a number of impediments that stand in our way. Some are unanticipated and coincidental, but they require a change, and they require what we're doing today, first and foremost, to really talk about this topic, to have a public discourse about it. Now, as we contemplated the utilization of this report, we quite purposefully decided that we would limit the number of recommendations so that we could focus our efforts as clearly as we could. And we decided to have 5 recommendations. These are all interconnected, one to the other, and they really speak to the statement of tasks that we had. The first of these, and you see before you a kind of shortened version of this, is that we felt that government health insurers and care delivery programs, as well as private insurers, should cover comprehensive care, including palliative care and hospice care, for persons with advanced serious illness who are nearing the end of life. Now, we defined comprehensive care as that which is seamless, high quality, integrated, patient and family-centric, and consistently available. And we went further, as you've already heard, to speak to the importance of individuals having access to palliative care and hospice care when they need it, either in person or virtually, and to also take into account that a part of that is recognizing individual preferences and understanding them, whether they speak to a desire for more or less care. But understanding individual preference really means that we need to have conversations about it. And as you know and you've heard and probably witnessed as well, these conversations are not happening in ways that uniformly meet individual preference. And so we felt, and part of our discussion today will focus on, the importance of coming up with requirements and mandates to make sure that these quality discussions are taking place. And so we said in recommendation 2 that professional societies and other organizations should develop standards for clinician-patient communications and advanced care planning that are measurable, actionable, and evidence-based. And further, we went on to say that payers and supporting processes and delivery organizations should adopt these standards and integrate them into assessments, care plans, the reporting of healthcare quality, and ultimately connect them to reimbursement as well. Now, saying that this should occur is absent execution if we don't really have the workforce to deliver this. And we recognized, as others have, that we've not done a very good job in educating and training doctors, nurses, social workers, clergy about these important issues. And so our recommendation 3 was to really try and make sure that that happens. And that's one of the goals of our meeting today. And we said that educational institutions, credentialing bodies, accrediting boards, state regulatory agencies, and healthcare delivery organizations should establish appropriate training, certification, and licensure requirements to strengthen palliative care knowledge and skills of all clinicians who care for patients with advanced serious illness who are nearing the end of life. And here I underscore that that training is for all physicians. We certainly recognize the importance of palliative care as a specialty, but it's incumbent on all of us who are caring for individuals, whether doctors, nurses, social workers, clergy, and beyond, we all play a role in this important effort. Now, the 4th recommendation speaks to another critical, important part of our dialogue today, which is the recognition that over the years since our healthcare policies were established, and unfortunately our healthcare system still not operating as well as it might, we hope that the Affordable Care Act will continue to move this agenda forward, but we have a long ways to go. And hence, we indicated in recommendation 4 that federal, state, and private insurance and healthcare delivery programs should integrate the financing of medical and social services. I want to underscore the social services as part of this effort to support the provision of high-quality, consistent care for patients that meets their values, goals, and informed preferences. And then further, we went on to say that insofar as additional legislation is necessary to implement these recommendations, the administration should seek and Congress should enact such legislation. The federal government should require public reporting on quality measures, outcomes, and costs, and encourage private payers and delivery systems to do the same. I hope we'll have significant dialogue, of course, about these integrated activities in our panels this morning. But we're here today as well, really focusing on our 5th recommendation. It's so clear that this is a difficult area. And we will hear in just a little while from Atul Gawande, who has just done a magnificent job, as you all know, in his leadership and certainly in his book that has made such a change for all of us and brings this issue to the public fore. But it's easy to have it dissipated. When we began our work and just prior to it, 2 words changed the agenda: death panels, bringing fear and concern to many individuals. And hence, we believed and recommended in our recommendation number 5 that civic leaders, public health and other government agencies, community-based organizations, faith-based organizations, consumer groups, healthcare delivery organizations, payers, employers, and professional societies should engage their constituencies and provide fact-based information to encourage advances in care planning and informed choice based on individual needs and values. So the real issue here is about improving quality and honoring choices and preferences. That was our objective. That's what we tried to speak to, and I hope today's important meeting will further elaborate on that. Now, I know that our next panel is going to bring together some real leaders in this area. We have Senator Susan Collins from Maine and Senator Mark Warner from Virginia, who are going to be here with us, and Dr. Zhao is going to introduce the next panel. Victor, I turn it over to you. Thank you.